Actually, we are in the middle of the storm with COVID-19 now in our region. It is really, really difficult. However, I'm grateful to be here with you this afternoon. So, if we can have the next slide, please. Just to remember that anticoagulation has begun, the problem of anticoagulation during extracorporeal renal replacement was born together with the extracorporeal renal replacement because, since 1914 from Abel studies, the problem was how to maintain the patency of the circuit and how to minimize patient complications. Next slide, please. Because we know that the problems are with the sites of possible clot formation from the hemofilter to the catheter to the chamber and the different lock and stopcock connections. Next slide, please. When the classical, next please, the classical site of action of effect of coagulation during renal replacement is believed to be the intrinsic pathway. Next, please. Because it is possible that the interaction with the membrane surface elicited different the activation of different point for the intrinsic coagulation system, but presently it is clear that the reaction is more complex and not completely understood because there is not only the intrinsic pathway but also the activation of tissue factors, leukocyte, platelets that can play an additional role as well as thrombin activation. Next, please. We know that there are other problems, other reason for clotting, not only the contact between the blood and the membrane, and these possible reasons are hemoconcentration, the technical ones as vascular access, patient-dependent factor. What is the real amount of this problem? In the next slide, we see that there are a percentage that goes until 25% of patients in which the CRRT is discontinued because of clotting, and mainly because of clotting in between the filter. Next slide, please. So, what can we do to improve? Next, please. To improve the circuit life. On one side, there are measures that are non-anticoagulant measures that are also important, such as the reduction of stasis, and this deals with the vascular access. But I would like to underline also the importance of training. It is not a small problem, the one of the reaction time to alarm and the right recognition of problems such as the catheter kinking. So training, mostly nurses training, is really important. On the other side, there are also techniques to optimize the setting. But in the next slide, we can afford the problem of the other kind of measures, the one related to the use of anticoagulant, because the use of the anticoagulant is necessary to maintain the patency of the extracorporeal circuit, but we have the aim of avoid bleeding and patient complications And we would like also to use an inert surface blood interaction to minimize the activation of the intrinsic pathway and also of cellular activation. In the next slide, so there is possible to perform CRRT anticoagulant free. It can be considered in patient with high risk of bleeding, such as patient with liver dysfunction or coagulation disorder or any other contraindication. And we can also try to prolong the hemofilter survival by reducing hemostasis concentration with predilution and replacement fluid. But in the many patients, most part of patients, we use anticoagulant. So the ideal right anticoagulant should be one that is easy to monitor, that has not side effects, and has got also available antagonist. We do not have the ideal right anticoagulant, but we can act both on systemic and on regional sides. What can we do? On the next slide, please. Next, please. Okay, I went too fast, so that's I was just saying about the ideal anticoagulation. If you can pass the next slide. Okay, thank you. When we speak about systemic anticoagulation, we speak mainly about heparin, where we can either heparin or low molecular weight, because heparin acts mainly on the 9-10 factor and on thrombin, and also acting on platelet aggregation. Heparin can be given both on the, near the filter as in the pre-circuit and is a systemic agent. Next, please. Next one. No, sorry, the previous one, please. Sorry. So the other possibility is a regional anticoagulation by citrate, and that acts against the calcium, any point of the coagulation cascade in which calcium is involved. And in this way, we act directly on the circuit and on the filter. Next slide, please. We can have also the possibility to use the other techniques such as flash, filter flash and lines flashing. But the most important thing is the use of the choice of the CytoSorb. This is the next one, please. This is the theoretical encadrement. When we speak about CytoSorb, CytoSorb works in combination with the other extracorporeal treatment. So the choice of the anticoagulant can be a crucial point. Actually, CytoSorb can be used both with heparin and also with citrate. And the key point is that anticoagulation must be fully effective at the start of the treatment. Sure that the anticoagulation is correctly, adequately titrated. Next slide, please. What about heparin? We have already said that we use heparin without special adaptation, so there is no special protocol for CytoSorb, different from the protocol that we use for other renal reparation therapy. We must obviously check anticoagulation with PTT or also with point of care such as HCT or also viscoelastic systems. Next slide, please. And in the next slide, we have next, please. Okay, what about citrate? Citrate, in this case, the citrate is regionally administered, so also in this case, there is no need of adaptation or protocols adaptations, but we have to monitor calcium by dosing systemic calcium and total and ionized and post-filter ionized calcium. So the monitoring is mainly on the calcium pathway. Next slide, please. Among the many works that evaluated the usability and usefulness of CytoSorb in many clinical settings, I would like to remember this trial in which CytoSorb plus CRT plus CytoSorb was performed, and with citrate solution without problems, but also the problem without severe hypocalcemia. So, and without the need to dose or to the dosing or to perform calcium substitution. So a right dosing of the anticoagulation can be performed safely and effectively, and hence long adsorber lifetime. Not only in these patients, there was also an improvement of hemodynamics. Next slide, please. What about COVID-19? COVID-19 is characterized by complex thromboinflammation problems, broad spectrum. Thromboinflammation is not typical only of COVID-19, but it can be found in a broad spectrum of the microvascular dysfunction. Next slide, please. What happened in this case? We know that patients with COVID-19 have a significant hypercoagulation. They are mainly characterized by D-dimers elevated until 3, 4, 5. We observed even tenfold increase versus normal levels. So it can be considered an hypercoagulable state. The mechanism of this hypercoagulability are unique between the inflammation, so the cytokine storm, and it can be defined such as an inflammatory thrombosis. Next slide, please. In this slide, no, so the previous one, please. Okay, there are the postulated mechanism, the previous one, please. It was too fast. The previous slide. Okay. Okay, don't worry. You can keep this one. Don't worry. The mechanism of coagulopathy are probably different because there are, of course, risk factor, patient-related risk factors, underlying disease, together with inflammatory response, and that can interplay. But the problem in COVID-19 patient is, for these reasons, a systemic problem. So it is not related to the extracorporeal circuit, but there is a patient with an anti-inflammatory hypercoagulation state. Moreover, we know that the most part, I dare say, more than 90% of COVID-19 patients are already under anticoagulation with heparin or low molecular weight heparin because of their weight. So next slide, please. We can go to the following one also. Okay. We saw what, the previous one. So we can have in COVID-19 patients an acute kidney injury, that can need supportive care, and it is well accepted that the supportive care, they are patients at risk of developing acute kidney injury, in which, following the classical standard guideline, we can decide the moment of continued renal replacement therapy. We also know that in COVID-19 there is a cytokine storm, so it is possible to use a strategy for cytokine removal in these patients. Next one. When and how? Next one. The cytokine removal is can be used whenever a cytokine storm is present. So cytokine removal, a method for cytokine adsorption, can be used together with other strategies that depends on this special single patient's characteristic. So that can be must be evaluated case by case. But we can now today say that if a patient has got evidence of high circulating cytokines or an inflammatory status with hemodynamic instability, there is a strict indication, there can be a strict indication for cytokine removal. Next one, please. We can, so my conclusion are that firstly, the right anticoagulation with the CytoSorb is not different from other, for all the other renal replacement therapies. So we can use regional anticoagulation or systemic anticoagulation. Both heparin and citrate must be used with the same doses without different titration, no special adaptation. In the specific case of COVID-19 patients, in these patients, systemic anticoagulation is mainly needed. Many patients has already systemic anticoagulation, but the dosage can be higher due not because of CytoSorb, but because of the hypercoagulating state. And hemoadsorption with the CytoSorb can be used whenever there is a clear sign of cytokine storm. Thank you very much.